we are all aware that there are various lasers to treat vascular lesions. The first one was, of course, the green laser, and then later on, the pulse dye laser came into existence. At that time, it was 577 nanometers, and then later on, they extended it to 589. So Dr. Huang will tell us why, whether it's any difference, why we need to extend the wavelength. So if you look at the absorption curve of hemoglobin, you find that there are two peaks. So we were actually concentrating on the green-yellow light. But then because of the depth of penetration, some of our lesions are too deep. So the next laser that came in was a long pulse Nd:YAG laser to target at the other peak here. Then subsequently, we have other lasers like the yellow lasers, and of course the non-laser, which is the IPL. Okay, so now I will then introduce my first speaker for this evening. How do I get all of this thing?
Okay, so can you see my slide now?
Yes.
Okay, it's okay. Let me see. Okay. Okay. I'm Dr. Huang, currently practicing in Taiwan. I would like to focus on the paradigm shift which happened in pulse dialysis in the past 20 years. I have no conflict of interest disclosure. The pulse dilator was the first laser specifically developed for the treatment of vascular lesions. And 577 was the first pulse dilator, and its wavelength is one of the absorption maximum of oxygenated hemoglobin. But why 577 was out, and the risk of crusting, blistering, and pigmentary change was too high because of high level of melanin absorption, which induced unpreventable epidermal heating. In addition, the penetration is less than 1 millimeter. So the wavelength of the laser use was shifted from 585 in early 1990s, and then after year 2000, 595 almost replaced 585.
Pathologist. Patrick has highlighted the paradigm shift in management of Port Weinstein based on the selective photodromolysis concept. I would like to move on to paradigm shift in management of infantile hemangioma, which happened in the year of 2008. In 2008, the beta blocker, both topical and oral, have shown to be effective in management of infantile hemangioma. Before 2008, most of patients with infantile hemangioma, they require no active treatment. But the percentage of patients require active treatment has increased significantly after 2008. And the main reason is because of propranolol, atenolol, and timolol. I remember when I first joined dermatology in the year of 2000 until 2008, basically when we have a child with infantile hemangioma, the treatment is either no treatment, or with the patient have a superficial hemangioma that affect a cosmetic concern area, we will prescribe them with pulse dye laser. If the patient have a mixed hemangioma that compromise the function of the vital organs, then we go for oral prednisolone. And after 2008, we have propranolol, atenolol, and topical timolol. Over the last 12 years, oral propranolol basically has completely replaced the role of oral prednisolone. I could not remember when was my last prescription of oral prednisolone on patient with infantile hemangioma. Whereas for superficial hemangioma that related to cosmetic issue, then we will combine either timolol with or without pulse dye laser. Some of you might ask why no longer using prednisolone, because the dose that we used previously to get the anti-proliferative effect is not 0.5 milligram per kg per day for 2 weeks, but it's 2 to 4 milligram per kg per day for 6 to 9 months, which is very heavy, and inevitably they end up with moon face and also buffalo hump. Propranolol.
All right. So there are a few things that I want to discuss in addition to what you have put up for discussion. First is the outcome. We find that after so many years, the outcome is still not very good. I mean, we get maybe up to 70%. So what are your options for these people? What if, in your practice, do you get better than 70% clearance or?
Myself, it depends on the age that I initiate the first and how frequent. Generally, if let's say the result is not up to my expectation, usually I will increase the spot size from 7 to 10. Of course, I don't have the 12 at the moment. And secondly, of course, increase the fluence until there's no blister, but yet I produce the purpuric reaction. And thirdly, also I increase the pulse duration, trying to adjust the pulse duration from 0.45 to 1.5 and sometimes to 3 accordingly.
Do you find that after treating for like 2 years, you find that the improvement is like very minimal?
Yes, some of them is like 30% to 40% of them, no matter what I do, it still remain the same, especially those with soft tissue hypertrophy. It's not the vascular blood type, not the hypertrophic, but when we have done a MRI over those areas that have underlying soft tissue hypertrophy, and there's no underlying venous or lymphatic malformation. We do have a subset operation of around 30 to 40%. They are, no matter what parameter I change, still remain not up to expectation.
In your
Okay. Hi, thank you for inviting me, Dr. Patrick. My name is Michiko Nagahama. I work at the Kobe Century Memorial Hospital in Kobe, Japan. I am specialized in laser treatment for the birthmarks of the infants and the children. I have treated a lot of babies with capillary malformation, infantile hemangioma, nevus alter, aberrant of Mongolian spots, and so on. Today, I show the most difficult case through my whole experience. So,
you want to say anything, Patrick?
Okay, thank you so much for joining this great session because, you know, pulse laser is not a really commonly used laser especially for common dermatology clinic. So there will be, most of the attendees probably just only have limited experience, but before they think about purchasing a new pulse laser or vascular laser, I think this session will be a good guidance to their if they would like to buy. Yeah, so thank you so much for your wonderful presentation, and I think most of the attendees really enjoy our conversation. And thank you so much, Joyce. Thank you for your sharing. Thank you.
Thank you, all of you.
Thank you.
Good night. Have a good weekend.
Good night.
Bye.
Good night.
Bye.
Good night. Bye-bye.